Good afternoon, and welcome to the National Association of Counties virtual learning session, How Are Counties Transforming Human Services Delivery Systems? This virtual learning session is a 6-part series of NACo's Transforming County Human Services Network. This is a community of practice that allows leaders to network and engage in peer learning and educational activities that is specifically designed for cross-sharing and exploring innovative models and best practice solutions for modernizing county-based human services systems. We know this topic is really important to counties as they invest in $63 billion in federal, state, and local investments in these critical safety net services. We're very excited to kick off this network, which is created for county leaders, both elected and appointed leaders who are interested in exploring new investments and policies in human services. And through this work, we're learning that counties are improving their systems and promoting better outcomes for children, youth, and families. So we'll keep you abreast of future programs and events that are available to counties through this network. And I'll include how you can sign up in the chat. I'd like to thank our partners, the KPMG for their gracious support, for Whit O'Brien's, and for Verity Educational Services for their partnership and gracious support. Next, I'd like to introduce Vivian Damien. She is the Executive Director for KPMG through their Healthcare, Government, and Infrastructure and Solutions Management and Consulting Division. We're very pleased to have KPMG join us and lead a group of phenomenal panel speakers all around the topic of transforming human services. So truly appreciate your partnership, and I will kick it over to Vivian.
Thank you. Good day, folks. My name is Vivian Damien, as has been indicated, and I'm an executive director with KPMG's Government Public Sector Strategy Practice. I come with 27 years of experience, and I started my career as a social worker and reached chief executive level while in industry. I have been with the firm for the past 7 years, conducting the majority of the behavioral health work across North America. Our team focuses on supporting counties on strategy and operational performance and efficiency transformation across multiple sectors, which include justice and the public safety, transportation and infrastructure, housing and community development, and health and human services. We have supported counties across the nation and to improve their efficiencies and outcomes, including Pinellas, Indianapolis, Santa Barbara, Sonoma, Hamilton, and St. Louis, to name just a few. We are very excited to be partnering with NACo on this new initiative, and today we are discussing how county leaders are transforming their human services delivery system by applying forward-thinking, innovative approaches that focus on whole-of-person outcomes and across-system collaboration to improve the lives of residents and communities. Our aim today is to understand some local approaches for advancing human services transformation and person-centered systems. It is also to examine approaches for improving resident outcomes and preventing and reducing interactions with downstream systems. And finally, to explore financial approaches to achieving equity using federal funded streams, state-based opportunities, and local recovery efforts. So why is human service transformation important? When counties engage KPMG, it is often because they are focusing on solving a specific operational issue or a multitude of operational issues. Often they include poor access to care, high utilization of either crisis services or hospitalizations or justice systems. I'm going to give you 2 high-level examples of our recent involvement. One was with the Riverside County, where we were engaged to assist them in understanding the high unmet needs and the low utilization of their services. We focused on redesigning their case management, standards of care, implementation, and supported a 16-week implementation support, which was side by side with both their supervisors, directors, and chief executives. Within 16 weeks, we were able to assist them in getting to 95% of their overall targets, which included servicing an additional 1,300 clients a week, which totaled approximately 4,000 additional services a week with the same amount of resources. That was one example. Another example is Pinellas County, but I will not take the thunder of our first speaker. who I've had the pleasure of working with over the past 26 months in regards to the transformation of Pinellas County. And so I will do a quick introduction. And before I do that, we're going to do some minor housekeeping approaches. As much as possible, we encourage you as participants to participate in this meeting. When possible, and when you want to raise your hand, please do so through the Zoom function and ask the questions or add comments during the Q&A segment. You can do this by clicking on participants in the bottom corner of your screen and then click raise hands, and then we will be able to see it. You can also type your questions or thoughts in the chat as well, and I will be able to review that and I will repeat it out loud. However, we do ask that you please mute yourself unless you are speaking. And if at any point you're having technical issues, please call the tech support number listed on the slide or in the chat box. All right. I am now going to introduce our first speaker. It is with absolute pleasure that I introduce Karen Black-Yachim, who is the Human Services Director for Pinellas County Human Services in Florida. She has over 20 years of experience servicing the public health services and now overseeing more than $17 million in social services, which includes healthcare, behavioral healthcare, justice, customer protection, as well as veteran services. After Karen, we will have the pleasure of hearing from Barbie Robinson, who was appointed as the Executive Director of Harris County Public Health in Texas. Harris County Public Health is a national accredited county public health agency for the nation's third largest county, servicing a population of approximately 5 million people. I want to thank both of our speakers for joining us today. I will now turn it over to Karen. Karen, the floor is yours.
Hi, good afternoon, everyone, and thank you so much, Vivian, and thank you to NACo for having us here today to talk about our transformation. So again, my name is Karen Yachim, and I'm the Human Services Director for Pinellas County. I want to start off with just talking about the challenge. So what brought us to the beginning of our transformation? I'm sorry, next slide, please. To get a better understanding of Pinellas County, we are a small peninsula, 280 square miles in the state of Florida, surrounded by very, very beautiful beaches, very, very high tourism. But we were really facing with increased concerns regarding opioid deaths in our community. So as you can see, we have a population of about 1 million. And you can see we have continued to see increases in drug-related deaths and more specifically opioid-related deaths. From 2015 to 2020, we saw a 205% increase in drug-related deaths, and we saw a 29% increase in overdose deaths from 2019 to 2020. One of the stats that we really talk about is one person dies every 16 and a half hours in our county due to substance-related death. I will say that this trend has continued, and again, as a national trend, in 2021, we are probably going to exceed 600 deaths related to substance use concerns in our county. When we started our transformation, several of us visited Erie County in New York to learn about everything they were doing to tackle the opioid issues. We left there with a plethora of ideas, new initiatives that we really wanted to focus on. At the same time, our Board of County Commissioners had really had a lot of discussions about return on investment for behavioral health services, possibly investing in a Marchman facility, which the Marchman Act in Florida really is an act that allows for involuntary placement into detox for individuals who are a danger to themselves due to their substance use. When we were collecting all of these ideas, we met with our county administrator, who really had the brilliant idea to say, let's take a pause, let's work with a consultant to really help deliver a strategic plan for our community. In addition to the question related to the Marchman Act, we worked initially with the consultant on really, 5 key questions. So the first being, are we doing enough for the opioid crisis? Should we invest in this Marchman facility? Bricks and mortar is expensive. It takes a lot of time. Should we be investing more into case management to really work hand in hand with individuals who are starting and stopping treatment? Do we have enough data to really understand the needs of our system related to access, quality, and capacity? And do we have too many silos? So should we be looking at consolidating providers, streamlining services to really reduce the programmatic silos that we had in our community? Next slide, please. So we worked with KPMG. This started late 2019, right before the pandemic. And really the approach was, again, the strategic plan. So we did not want a study of our system that was going to sit on the shelf and really be kind of that retrospective point in time review of what we were seeing. We wanted our system to be elevated, and that really was the charge that we had asked KPMG. I want to take a minute on this diagram. This is something that KPMG worked with us to produce in our initial plan. And it's something that we still use today when we're looking at new grant funding, new initiatives. But really, what KPMG found in the reviews that they did with our stakeholders was that we as a system were investing significant resources in the top of the triangle. So the most severe, the highest utilizers of systems. And we were really kind of missing the opportunity to look at early prevention, early intervention services, so more of the base of that triangle. So why that's important is some of the recommendations that KPMG did really kind of was change management, both at the county and with many of our community stakeholders, to really kind of reverse funding, reverse looking at how we invest dollars and how we're really going to tackle some of the issues that we were facing in our community. Next slide, please. So again, our approach with KPMG, again, the strategic plan, we really wanted to find out from a wide array of community stakeholders what they were feeling were some of the roadblocks or issues in accessing treatment. And so we did supply KPMG with, I would say, 6 to 7 volumes of data. So previous studies, reports, evaluations on programs, outcome reporting that we had, outcome reporting from the state. But really the significant lift of this project was meeting with those community stakeholders. And so we, along with KPMG, met with over 50 community stakeholders in our community to really ask those questions about what was going well, what are the pain points with behavioral health, what do they think could help solve the opioid crisis in our community. And really what's important is the interviews included systems of care. So homeless services, child welfare services, justice services, primary care and hospital services. We were really trying to get, the information from those consumers, those systemic consumers of behavioral health services. And this also included our behavioral health providers as well. I will say that this work was not done in a vacuum. It was very transparent. We held public meetings, but a lot of it really was trying to get the intel of what systems were feeling, as well as some frontline staff and consumers of services. What we found is that there was a perception that the primary entrance into behavioral health services was through crisis. That really was the feeling from many of those systems of care, that there was this unknown point of entry from referral to first assessment to first service. The only way they knew their consumers would be receiving services if they were involuntarily Baker acted or entered into the crisis center or entered through justice. And again, when we're looking at that triangle, our goal is really to reverse that. So how can we streamline access into the services? What we also found, and really this kind of falls on the funders of services, is that programs have historically been built to fill gaps, to deliver very specific services, whether it's a federal funding, whether it's county funding, state funding. But when you have very specific programs that are built, you are building silos. You're building programs with very specific referral criteria, eligibility criteria, which not only makes it hard on the provider to manage, but it also makes it very difficult for the referral sources to understand who can get what service based on that eligibility criteria. Additionally, KPMG found through these interviews that as a system, there was a lack of data-driven transparency on performance. So while separate programs had outcome measures, performance measures that were tied to that specific funding, as a system, as an entire county, we could not answer if clients were in fact getting better, if we were seeing successful outcomes from programs, except if we took that kind of very programmatic granular look. Again, I spoke about the siloed funding, how it creates issues with eligibility criteria, but also places a very high burden on providers when they have multiple reports to complete with multiple different requirements. And then ultimately, kind of leading back to that first question, the findings really, what we found was that one facility cannot meet the needs of the entire population. So that led us to the strategic plan that we were charged with creating. And I can say KPMG provided us with 7 pathways that we as a system could move through. We again charged them with kind of prioritizing which ones we should start with. So the first that we started with was the optimal data set. So if you can move to the next slide. The optimal data set is also often referred to as a minimum data set. But this was really looking at health of the system measures. So as a county across multiple funding streams, how can we answer what does access look like for our system? What is the capacity of services in our system? And then ultimately, what are the quality indicators for services in our community? So this is an extremely big undertaking. We worked hand in hand with KPMG to facilitate several workshops with our providers. So first, collating everything that they are currently responsible for providing. And this includes county funding, state funding, federal funding, and then really meeting with the providers on saying, are those measures important to you as a service provider? Are they meaningful? And if not, what are meaningful services or meaningful performance metrics that they had ideas on? And so in multiple sessions, we came down with 29 indicators to start with that really look at access into services, and more specifically, capacity and quality outcomes for behavioral health case management in our community. The optimal data set is really, the behavioral health indicators for case management is step 1. And so how this is really going to be built is that the next set will be looking at probably outpatient indicators, possibly group indicators, and just and so on and so on. What we're doing now is we have built a public facing dashboard that really will focus, like I said, on the health of the system. So I don't know if other communities have this, but I always reference, in our community, we have billboards that look at wait times in emergency room departments. We don't have that view into the behavioral health system. And so this dashboard really is going to help us see what are the wait times from referral to assessment, from assessment to first service, from first service to first psychiatric evaluation, and so on and so forth. The goal really is that this public facing dashboard would be the top level. And then as funders, we can then take the next level to look at provider by provider. And really it's to look at what is working well with one provider and how can we replicate those outcomes across the system to really improve performance for our entire county. Next slide, please. The next transformation that we are currently in process with is a coordinated access model. And so in our community, during the interview process, what we continued to hear was, again, this kind of black hole of referrals. So once the referral is made, there was a real lack of understanding on wait times. Sometimes clients would start and stop with different providers, and so they would have multiple assessments across the system. And really this unknown approach. And so working with KPMG, this model is really designed for a one-stop, no wrong door approach in our community. So it would be a 1-800 number, a website, text, all of the above, where consumers and referral sources can make a call. They would have a level of care assessment completed by the clinician on the other side, and they would be able to book a live appointment for that individual, either via telehealth or with our local providers. They would have access to their system. And this way, they would be able to provide information on wait times to the consumer as well, but also wait times for the system. This process currently is in the procurement process. So we're in the very, very early stages of implementation. But we are very, very excited about this, because this is not only going to give us an eye as the system as far as where our needs are, where true gaps are, but it's really, really meant to deliver high quality services to our consumers, families, and referral sources to really reduce the burden on them. The hope is that even for uninsured or insured individuals, they can call, and this coordinated access model will know what providers take their insurance, what providers have certain wait times, what the eligibility criteria is, really to kind of remove that lift for case managers, remove the lift for the consumers, and really operate in a manner that really streamlines that process. We're currently, again, in the development of this, so we are making decisions on if this will intersect with our crisis system as well. So if someone is in crisis, could they deploy the mobile response teams? Would they have access to dispatching services out to the community? So we're kind of still in the decision-making process with this model. Next slide. And again, this is, we'll probably speak more a little bit towards the end of the presentation. But one of the, I would say, most interesting and things that I'm the most proud of for Pinellas County is that we have formed a Pinellas Integrated Care Alliance, which is a group of funders that work together to identify gaps. Our goal is to align contracting and business processes, review system design, barriers and outcomes, address social inequities, and really utilize data to make decisions. So in the state of Florida, we are not a Medicaid expansion state. So we have state-funded behavioral health services for the uninsured and underinsured, and we have managing entities. And in the Pinellas County, our managing entity is Central Florida Behavioral Health Network. Additionally, we have a child tax credit, and that created the Juvenile Welfare Board, which is a children's board or children's services council, where that tax is specifically used for children and family services. So the managing entity, along with Juvenile Welfare Board, the county, and then our sheriff, as well as our medical director for our public health system, we work together to form this alliance to really help make these decisions. Again, as we fund most of the services in Pinellas County, our goal really is to align contracting, to make things more streamlined, to align the key performance indicators across all contracts, which essentially should make it easier for providers to have one set of standards that they would be reporting on in that public facing dashboard. So I think that's the end of the presentation. If you have questions for me, I'd be happy to answer them.
Thank you, Karen. If people would like to either put up their hands or put their questions in the chat, we could take one question before we turn over quickly to Barbie. Okay, seeing none, if it's okay with you, thank you, Karen. Thank you for that presentation. I'm going to continue moving us along, and I'm going to turn it over to Barbie to present on Harris County Public Health.
Thank you, Vivian. Good afternoon, everyone. Pleasure to be with you this afternoon to talk about the innovative work that is happening in Harris County. We are in the process of transforming the way county government provides services to vulnerable populations, recognizing that they have shared needs across multiple systems, and how do we design systems that enable these populations to receive intensive wraparound services to meet their needs and to improve their outcomes. Next slide. Next slide. I'm not going to belabor the point in terms of demographics. Harris County is the third largest county in the country, a very diverse county, actually a minority majority county. And we have numerous challenges similar to other counties in the country with a high uninsured population, 15% of population living below the poverty line, 15% of the population lacking adequate food access, experiencing major food insecurity. Next slide. And so Access Harris County really is focusing on addressing this particular challenge, the challenge that we see with poor outcomes from single agency service delivery model. So what that means is, right, we have individuals who have needs across multiple systems, but they're left to navigate the siloed and fragmented systems of care because our systems are not integrated. So staff across programs do not systematically collaborate to support clients. We see inefficient service delivery as a result of that. And, our staff may know other folks in other departments and can refer someone out. But the reality is our systems are not on a macro level integrated and thinking holistically about the needs of the populations that we all serve that are shared populations. You couple that with siloed systems. So we're unable to share key information across programs that ultimately would enable us to more effectively deliver services, knowing that someone is homeless when an individual presents to our health systems, knowing someone has a behavioral health challenge when they present to our human services systems for Medicaid or food economic assistance. Having access to that information enables more robust service delivery because we better understand the population. You couple that with siloed funding, categorical funding, we're unable to really blend and braid our dollars. And what we see are poor outcomes. The lack of integration has created barriers for vulnerable clients. And we define vulnerable clients as those individuals that have multiple needs that are shared across our safety net systems. And what we see is poor outcomes as it relates to improved well-being and self-sufficiency. And of course, costly and administratively burdensome access into the system for those individuals who are trying to receive our services. Next slide. To illustrate this point, our clients are forced to navigate this siloed programming arc, right? So they have to identify and run around town or run around our county to access these services in a siloed way, sharing information. My name is Barbie Robinson, telling their story over and over again for the same types of information that most of us are mandated to collect in order to enroll in the services on the right. Next slide. And so our solution for Access Harris County is an integrated safety net system. And what that means is we've created, integrated care management teams that consist of frontline staff across all of the safety net departments that come together to create coordinated goals, shared coordinated planning for individuals that are entering our system. They're utilizing enabling technology through an integrated data hub, through a shared client record that provides a 360 view of who these individuals are and their needs across all of the safety net systems. And you couple that with access to a service portfolio or services and intervention portfolio that also includes the braiding and blending of our funding. And what we're anticipating and what we've seen in where I've implemented this model in Sonoma County is incredible outcomes related to housing and sheltering, improved and sustained engagement with behavioral health services and medical services, economic assistance that has resulted in individuals becoming more self-sufficient, food assistance, et cetera, which has led to more improved well-being and stability. Next slide. And so the key objectives that we're hoping to achieve through Access Harris County is to improve the health, well-being, and sustained recovery and self-sufficiency of the county's most vulnerable residents. And as I said, individuals who find themselves navigating that arc, needing multiple services across our systems, they are the most vulnerable by definition. And so our goal is to develop and implement a plan to coordinate agency services and reduce duplication of services, to improve integrated service delivery through a no wrong door access to the safety net system that ultimately results in more sustained engagement for clients, as well as to develop strategies and policies. What we've seen is that through this model of care, we're able to assess and refine our operations within our individual programs, departments, et cetera, for better utilization and better outcomes. And then, of course, the key objective is developing an integrated data sharing system, which is critical to support the care coordination across agencies. Next slide. And in terms of governance and leadership, we've established the Safety Net Collaborative, which includes the executive leadership across all of these different safety net departments: health, human services, housing, our justice partners from the sheriff's office, the district attorney, the public defender, juvenile probation, adult probation, workforce and economic opportunity, education, and then of course our internal service departments such as our county attorney, our IT department, et cetera. And, I often talk about, I've coined a phrase, collaboration without integration is just another form of fragmentation. And our goal and the value proposition for the executive leadership across these entities is one, a recognition that in order for us to be effective within our departments, we're really interdependent because we're trying to address holistically the needs of the individuals that we're serving. And we cannot do that remaining in our individual silos. And we really need to move from, we've come a long way. We're not competing against each other in swim lanes. We're kind of handing off to each other in terms of relay racing, but we really need to get to synchronized swimming where we're all in the pool together, working as one unit to produce the outcomes we want to see for the populations we're serving. Next slide. And this is just a list of the agencies here in Harris County that are part of the executive leadership of the Safety Net Collaborative. That Safety Net Collaborative is responsible for identifying the cohorts of populations that will be served through Access Harris County, to discuss other policy matters and operational issues as it relates to serving shared populations. Next slide. And so through the Safety Net Collaborative, we identified 7 priority cohorts of populations to be served. We're currently focusing on the top 4. So homeless individuals with physical behavioral health conditions, violence prevention, reentry, and transitional age youth. The other 3 populations are important, and to the extent that individuals with profiles that are reflected in the top 4, they will be participating in Access Harris County through those top 4 cohorts. Next slide. And so just to illustrate how this model works, I want you to meet Sam. Sam is a participant in our violence prevention cohort. He's a 16-year-old with disciplinary issues, starting to find himself intersecting with the criminal justice system. His family believes that he needs violence prevention services. What are the resources in the community to help stem the tide and prevent him from engaging in, criminal activity, violent activity? He's also in need of mental health services. He's endured trauma, as well as, his grandmother starting to think maybe he needs foster care services because it's becoming challenging for her to manage and handle and raise Sam. Sam may also be eligible for other services, educational services and support, housing assistance, food assistance, utility assistance, but his family is thinking about these primary needs as they should. However, next slide. When we think about his journey without coordination, his grandmother is going to present, she's going to navigate, she's going to run around town and searching for these services. She's going to do initial intake where eligibility is determined. She's going to tell that story that I just told about what her family is experiencing. There's going to be information, request loop, et cetera, to get enrolled in these 3 services. And what remains undiscovered through this system without coordination is that the other services that quite frankly may enable Sam to be more effective in the mental health, foster care, or violence prevention services have gone undiscovered, and limiting the ability to have great outcomes had we engaged in these other services as well. Next slide. And so Sam's future with his enrollment in Access Harris County is, as I said, there's not a wrong door. And so because we have teams of staff that are frontline staff across human services, health services, a probation officer, education services and supports, mental health, et cetera, those teams come together. They receive all of the information about Sam at once. They're gathering all of the key information through the intake process about Sam, and they're able to initiate the enrollment process. And rather than Sam's family running around town, this team is wrapping these services around Sam and bringing them to Sam and his family. And so what we see is an integrated, holistic approach, a thoughtful approach, a stepwise approach to how we're approaching service delivery for Sam. We all know what it's like when someone presents to our silo, and we recognize, right, or they're telling us their story and they have these other needs, but quite frankly, there's not a lot that we can do about that because of the way that our systems are traditionally set up to serve people, to focus on our individual discrete unit of service. Next slide. And so there are, many opportunities. As I mentioned, Access Harris County is built off of the model that was created in Sonoma County that is being replicated across the country. And so that model began with a key organizations or departments, human services, health services, the probation department, pooling some initial funding to prove the concept. And as a result of that work, we were able to then get additional funders across those safety net departments to contribute to blend and braid our dollars to create the technology. We in-kind donated our staffing for this model, right? They're already doing the work, they're just doing it in their silo. So bringing them together enables them to do it more effectively. And so I'm happy to report that here in Harris County, there's been major investments and commitment of ARPA dollars to not just fund the portfolio of services. We focus a lot on, the what, right, which is the service delivery. This model is really focusing on the how so that we can enable our systems to be more effective. Next slide. And so this African proverb really reflects what we are trying to achieve through Access Harris County. And it says, when spider webs unite, they can tie up a lion. And if you look at this spider web, it's reflective of our systems, our funding, their gaps, their holes, their broken pieces. However, but when we bring our spider webs together across the safety net, we're able to tie up, the lion of homelessness, the lion of food insecurity, the lion of, poor medical and health outcomes, behavioral health outcomes. And so I'm super excited about the work and open to sharing any information I can about how we've stood this model up to achieve better outcomes. And as I said, this is the way that government should function, in terms of meeting the needs of vulnerable populations, not just focusing on getting them into the safety net and our discrete services, but how do we get them out of the safety net to improve well-being and self-sufficiency. And with that, Vivian, I'll turn it back over to you.
Thank you, Barbie, for a phenomenal presentation for you and Karen. I'm going to pause for a second, and what we're going to do, just recognizing that we are tight on time, we're going to do a quick survey, and then we're going to turn it over to the participants to see if they have any questions, and if not, I have some questions for you. Rashida, oh, perfect. We would love to know, has your county, based on the presentations that you've just heard from both Barbie and Karen, has your county embarked on a human services system redesign efforts? Yes, no, I don't know, or I'm interested in learning more about the topics from either of our speakers. So if you could, do they just vote directly, Rashida? Yep, okay, perfect. If you just click, and then we will be able to see what the results are. And as folks are doing this survey, if you would like to prepare your questions, we could either do it, you could either do it via the chat, or you could raise your hand to ask the questions directly to either of our speakers in regards to their initiatives and some of the outcomes that they're currently or they have currently achieved. And Rashida, you'll let me know when the survey is complete. Oh, here we go. Now I see it live. Perfect. Thank you. Good. We have more that are interested in redesigning efforts. That's wonderful. At 43%. Wonderful. 36, they're not there yet. 4%, I don't know. And I'm interested in learning more, 21%. Terrific. And I know that the information for both Karen and Barbie will be made available. Wonderful. Thank you, folks. That's great to see that there's initiative on your end. We do have a couple of questions in the chat. And so the first question is in regards to, did Harris County or Pinellas either of them, did they include individuals with lived experience in your projects and your efforts? I'll turn it over first to Karen for that response.
Sure, I can say in both the initial strategic plan as well as the ODS and the CAM, we have included NAMI, which really kind of is the voice of the consumer. And then we also included a religious organization, and we invited all of them to come and share their personal experiences interacting with the behavioral health services in our community.
Thank you, Karen. Barbie?
I would just add that individuals with lived experience are frontline workers in the system. And so they're participating on those care coordination teams to help inform the goals, the coordinated goals for other participants. And the beauty of this model is that those with lived experience that are often served through this model want to be involved, want to know, once they're stabilized and get on their feet, they want to know how can I get involved? This was a great experience and transformative for their lives.
Perfect. Thank you, Barbie. Hopefully that answered the question. And by all means, if there's more to that question that you'd like to know, include it in the chat or just raise your hand. The next question, there's a lot of questions. Hold on, now I need to go back up. The next question is from Janie, and I'm sorry if I'm not pronouncing that correctly. For both presenters, I'm wondering how you got a nonprofit that do some of the work to come on board. Any suggestions would be appreciated. So really in regards to engagement, which was one of our initial questions to both speakers. I'll begin with Barbie.
Yeah, I think it's the value proposition. I think there's a recognition that the interrelationship and interdependency of the different services that are provided by the safety net and how fragmented that is. There's a desire, a lot of the community-based organizations here in Harris County are the front leaders in terms of delivering services. And so they see the value immediately more, maybe sooner than government agencies did. So I think it's really around presenting the value proposition for the outcomes that we'll see through a holistic model.
Thank you, Barbie. Karen, would you like to answer?
Sure, and I can just say that this is a continued work in progress for us. So I think it's a lot of upfront communication. It's inviting them to the table, inviting them into the process. But I really think going back to the collective group of funders, it's working together and kind of providing that anticipatory guidance that these will eventually be in the contracts. So again, it's partnership, but then also that kind of contractual piece in collaboration with the other funders.
Terrific. I'm going to just ask one question to add to that. How did you get your boards on board? How did you get your boards on board, your board of commissioners on board? Mm-hmm. Barbie?
Yeah, I think this is a critical component. I think to the extent that our elected officials want to see better outcomes, it's not about the what. We could always make more investments in the services and the portfolio of interventions. It's really the how we're delivering them that impacts the outcomes. And so when we're talking about outcomes, return on investment, efficiencies, we were able to, get our board of supervisors in Sonoma County and here in Harris County very much interested, regardless of what side of the aisle they sit on, right? Whether they want to see improvements for the lives of those we're serving, efficiencies, this model of care addresses all of those. And we were able to pass a resolution. I know there's another question about, how did you get government agencies on? The Board of Supervisors passed a resolution that says, thou shalt create this system and this model. Whether I sit in this chair or someone else is sitting in the chair, it's an expectation that whoever's leading the county, that they're transforming a government by creating this system.
Terrific. Thanks, Barbie.
Karen? Sure. I can just say for us, I really feel like this was not a lift at all. So our Board of County Commissioners is heavily invested in behavioral health, in human services for their residents. They often get calls from their constituents about access to care and concerns with the opioid crisis in our community. So when this was presented as a strategic plan and really how to move us forward, they have been amazing. So it really was not a lift for us at all.
Terrific. Thanks, Karen. The next is from Charles. Were both of these projects a result of changes in community dynamics since the start of COVID, or did they exist prior? And I'll start with Karen on this one.
Sure, I can say for us, it started right before COVID. So the strategic plan, we initiated that in December of 2019. I think that in our community, COVID has really strengthened the relationships between government, not-for-profits, and just the community in general. So I think the timing was really right for this to be working alongside the pandemic.
Yeah, and I would just add to this, Charles, is that we had to pivot. We don't typically do engagements of communities and partners and Board of Commissioners virtually, but we had to pivot and we had to learn the new dynamics of our new world, as I like to call it, since the pandemic started almost 2 years ago. Barbie, I'll turn it over to you.
Yeah, so as I mentioned, this was created in Sonoma County. I spearheaded this effort in California and brought the model to Harris County. So in Sonoma County, it started out of another emergency, fires in 2017. But here in Harris County, we've started this in COVID with a recognition that COVID has magnified the challenges of fragmented services. If you think about it, folks that are struggling in COVID have the multitude of needs across our safety net systems. And so it just kind of highlighted how individuals have shared needs, their shared populations across our safety net.
Thank you, Barbie. The next question is from Craig, and it's what was the resistance response from key government stakeholders being forced to collaborate when they are so used to being siloed, and how did you overcome this? I'm going to just add to that question, if that's okay with you, Craig, is that there is key government stakeholders, and then there's the for-profit organizations that are sometimes engaged in providing care, or non-for-profit that are engaged third parties. Barbie, I'll turn it to you.
Yeah, I think it goes back to my original comment. There is the value proposition and the recognition that, the overcrowding in jails, the backlogs in court cases, the continued need for financial assistance, food assistance, that individuals are just in a cycle. If they do get into the safety net, we're not getting them out of it. And so there's a recognition that the outcomes that each of our safety net departments want to see requires that we link arms, we get in the pool together, and we get to synchronized swimming. So that's the value proposition, that we're not seeing the outcomes we want to see, and our dollars are being spent, and there's an expectation of accountability to that.
Barbie, I'm going to steal the synchronized swimming from you. I got to tell you, I love that statement, and I'm going to use it again. But I will quote you if it makes you feel better. Karen, over to you.
Yeah, I mean, really just kind of to echo what Barbie said, I think when we've worked with the other systems of care, so justice, child welfare, the homeless system, they cannot do their work with their clients in a successful manner without working very closely with behavioral health providers. So it's really looking at that outcome, the increased communication, and really kind of peering in the window of what the wait times are, what does access look like, and then really what's the return on investment. So if clients are going through services and they're receiving high outcomes, those other systems also benefit. So we have less people in jail, we have less children and families engaged in the child welfare system, or those cases are moving faster because of the intersection with behavioral health.
Thanks. Karen, I'm going to just ask an additional question again to Craig's question, and that both you and Barbie touched upon in terms of outcome measures. What tools are you utilizing, or are you about to utilize, to demonstrate what those outcomes are? One of the things for us is that if it's not measured, it's not done. And so what are both of the counties doing in regards to that?
So for us right now, again, we've really focused on the work that KPMG provided to us, which was the 29 key performance indicators related to access, quality, and capacity. So are we seeing more individuals with stable housing? Are we seeing less returns to the crisis stabilization unit? Are we seeing less recurrence of arrests? So those are some of the key indicators that we're looking at with this optimal data set.
Yeah, and I'm going to just add, and the next step would be the dashboard that we're assisting in developing, because the goal is for Pinellas County to demonstrate this to their partners and other government partners. Terrific. And Barbie, what is it that Harris County is currently doing in terms of tools for outcome measures?
Yeah, the beauty of the technology that we'll be deploying is we have the ability to, at the macro level, because we have an integrated data hub, we're able to see that universe of existing participants and match them across the systems to come up with a profile of vulnerability, the service utilization, the cost of those services. So we're able to drive policy and operational and program decisions from that macro perspective. But we're also able with this technology to get operational reports. So what we saw in Sonoma County is, for example, beating out the national average in terms of placement from sheltering into permanent supportive housing or affordable housing. The national average is 8%, but in Sonoma County, we were at 30%. And so with that kind of return, and 85% of participants actually getting enrolled in Medicaid and getting a medical home and using those services. So we're able to get individual level reporting, cohort level reporting, all cohorts, participants, and the outcomes that we're measuring. And we have robust KPIs that we're measuring to demonstrate the return on investment.
Terrific. It sounds like both counties are really focusing on a population health approach based on the data that you're receiving, which is wonderful. Next question is the network only for counties? There are critical cities and state agencies that are decision makers as well on health and human services delivery. Without them at the table, there would be a gap in creating a redesigned system.
I can answer that. Yes, the network is open for everyone. We partner with national organizations like the National Governors Association and National League of Cities, which is actually co-located at the NACo office. So we see them as critical partners, and we can integrate them into more strategic discussions through the network.
Thank you. Next, does Pinellas have any initial outcomes to share, or is it too early? Are you seeing any increases in those outcomes of interest? You mentioned like referrals, assessments, and initial treatment for OUDs.
I would say we are still in the very early stages. So I think in a few months we would be happy to share, but we have our dashboards built. We're meeting with our initial providers to roll this information into contracts, but we're not fully receiving all data from all providers to really indicate the health of the system yet.
Thank you. Next is from anonymous attendee. I apologize if this was mentioned, but what is the annual budget for each of these projects? Barbie, do you want to begin?
Yeah, I think, we'd have to put it in buckets. So enabling technology, which is, one of the legs of the three-legged stool for this model, it's one cost, but it's also scalable, right? I've talked a lot about, depending on how many cohorts you're talking about, how many systems you're talking about integrating, there's a cost associated with that, right? And so, if you're talking about the number of cohorts, there's a cost in terms of the number of staff across those different safety net departments that come together. So whoever's asked that question, I'm more than welcome the opportunity to speak with them offline, because it's not a straightforward question. It really depends on how you design your system and the number of cohorts and the number of agencies that are participating.
Terrific, thanks, Barbie.
And so for Pinellas counties for the ODS, so aside from any of the consulting fees, for the optimal data set, KPMG recommended that we add 2 FTE to our department. So we hired a behavioral health data scientist, which really will lead the future of the key performance indicators, and then a data analyst who's really responsible for dashboard creation, the visualizations, kind of that back end heavy lift with the providers, taking it from spreadsheets into this live Power BI dashboard. So really at this moment, the ODS is the cost of those 2 FTEs. For the CAM, as I stated, we're still in the procurement process, but we have allotted, I would say, $1 to $2 million on a go forward basis for the operation of the coordinated access model.
Terrific, thanks, Karen. Next one would be, what would be needed legislatively to make this a standard national model for either of these? Great question. I'll turn it over to Barbie first.
Yeah, as someone who, had 15 years at the Centers for Medicare and Medicaid Services before going to the local level, this is, my goal is for, counties to collectively lobby and advocate. And this is why it's great that NACo has this forum for us to come together for this kind of transformation, transformation for how we deliver services. And so I think advocacy, the more county entities that are leveraging these models to improve outcomes, the better we are in terms of being able to advocate at the state level, at the federal level. You know, that view, right? Someone once said, right, the feds have all the power, the feds have all the money, the states have all the power, and the locals are left with the problem. And so, you know, it behooves us to have transformation at the state as well as the federal level for them to come out of their silo so that they're designing appropriating dollars that flow to states with the expectation that states have these models in place, and in turn, counties have them as well.
Great answer. Thank you, Barbie. Anything from your end, Karen?
I just want to say, you know, once we're still in, like, I would say, the proof of concept. So once we have kind of fully vetted the proof of concept in both models, we fully anticipate really advocacy, if this is working, that this should be the state model. And then, of course, taking it, you know, even further.
Terrific, thank you. And I know that there's other jurisdictions globally, nationally, globally, where they have done that, and they have developed, you know, great dashboards that are for the country. And I look forward to that one day, that it's at a state level and at a country level. I'll pause and ask if there's any other questions or comments that I may have missed. And Rashida, you're going to keep me honest if I've missed any of them. Okay. Any other questions or comments from the participants? I see none. Okay. Wonderful. So we will, our virtual learning series is coming to a close. We want to thank you all for joining us today. And I particularly want to thank both Karen and Barbie for taking the time to do this with us today and to share your expertise. To sign up for more events, please go to NACo.org. The information is also in the chat. We also ask that you complete a short survey to share your feedback on today's session. We want to thank you all for attending, and we ask that you have a wonderful day and a safe weekend. Thank you, folks.
Thank you.
Okay.